Well, thank you for being here. It is truly a great joy to speak with you about a subject that's quite dear to my heart, having had it myself some years ago. So I thought we'd start off with a fairly happy snap from Christmas. That's the beginning of the overland track at Cradle Mountain, looking down on Dove Lake, number 2 and 4 offspring, who dragged me up a couple of mountains, and it took me about 3 weeks to recover. But that's nice and happy. So we then, with all those nice feelings, we then go to locked jaw and facial pain, which probably induces a few other emotions. And the reason I've segued that is to emphasise the emotional content of facial pain. Right. Moving on. Yeah, you can go beyond blue with facial pain, because there's many a time somebody will say, "This is ruining my life. How do I get rid of it?" My description of locked jaw, facial pain, not all facial pain is related to jaw function, but I would suggest 90, maybe 98, close to it, probably is, or certainly has a component of jaw dysfunction. And we're about to find out why that may be so. I'd like to emphasise a little bit of anatomy. Condyle sitting in its fossa, middle cranial fossa immediately above external auditory meatus. This is the only joint I know in the body that has a muscle attached to its meniscus or disc. What other joint has that? So this is a wild little joint for many reasons. It's got a nice big muscle attached to the neck, and it's got recoil elastic tissue behind. So that elastic tissue is opposed by the superior head of lateral pterygoid muscle. Okay, keeping that in mind. Locking generally means a frozen joint with muscle spasm, but it can just mean a fairly frozen joint. So quite often the retrodiscal tissues become squashed, and they're highly sensitive, and the muscles spasm. And perhaps maybe at the end of the talk we'll discuss my technique of disengaging that. So remind me when we finish. Okay, MRI time. It's a beautiful way of looking at TMJs, but expensive, and not everybody enjoys MRIs. External auditory meatus, fossa, condyle sitting in its closed position, meniscus on top, retrodiscal tissues here, superior head of lateral pterygoid here, and lateral pterygoid. So, moving forwards, moving out of its fossa, the retromandibular tissues stream in to fill the void. Capsule attached here and here, superior head of lateral pterygoid pulling the meniscus forward, meniscus staying on top of the condyle. Almost fully forward, Oh, the other thing to mention is most of that movement's translational. It's just moving bodily forwards. It's not actually rotating all that much at that stage. So the jaw actually has a huge range of options in terms of its direction and movement. Almost fully open, not quite. Started off here. The retromandibular tissues stream in to fill the void. A most amazing process, and meniscus still between condyle and eminence, but has moved back on the condyle. Superior head still pulling it, lower head pulling the condyle forward, and all this tissue pulling controlling the forward movement of the meniscus. It's unbelievably complex and wonderful, and mostly it works. You might also like to know that in studies in cadavers, when the retrodiscal tissues are pulled, in about 30%, the malleolus in the middle ear moves. So the discomalleolar ligament actually is still patent in about at least 30% of cadavers, if that makes any sense. Ear symptoms can be understood, perhaps, not always, by the interaction of the TMJ with the middle ear. Oh, by the way, that's all first branchial arch embryologic development, so it's not all that hard to anticipate that they might be connected in some way. So, an unbelievable journey. That's more than 1.5 centimetres. It's probably the only joint I know that disarticulates itself in normal function. So that's wide open. That's 40 plus 45 millimetres opening anteriorly, and that's actually, it will go a little bit further than that. So it's an amazing physiology. Well, it's a bilateral system. We don't think of the TMJ as a single joint. We think of it as a bilateral system. So really, if we have one joint that's a bit wonky, you really need to be cognizant of the other joint as well, what's going on. And it's a system within a system. It's the system within the head and neck system. So we have a joint system, powerful, 150 psi biting force approximately in normal circumstances, but it's housed in a bigger system, the head and neck. So, what does this all mean? The head is 5 kgs. It's heavy, a lot of brain work sloshing around in there, and the entire weight of this apparatus passes through 2 tiny lateral facets or articular facets on the axis C2. And the reason that can work, and usually does quite well, is that the atlas acts as an interposed bearing and directs the net vector of force onto the middle facet, or there's 3 facets of the lateral articular facets of axis. And surprisingly, or perhaps not, the cranium rotates around the perpendicular to the atlas. So allowing for a little bit of slippage, which varies between individuals, you can absolutely accurately determine the flexion and extension at point of the head and neck. And it's very accurate, and it has to be to bear the weight through really tiny articulations. And the clinical implication of that is, if we raise the head, say we raise this point up, and it's going to rotate around that, and these vertebrae don't move too much, you increase the volume of this area markedly. And just another little point, the floor of the nose generally points more or less at this point here. So if we're extending, we can imagine the head and neck extending around there. Happy to have questions about that now or later. But so jaw system is a system within a system, and we must also always be cognizant of what's going on in the head and neck and body postures. Okay. It's a fibrocartilage line joint. Fibrocartilage means there's cells in the cartilage. The only other two moving joints that have fibrocartilage are acromioclavicular and sternoclavicular, neither of which are weight-bearing joints or under normal circumstances. And they don't do very well when we run into opponents on the rugby field either. So, but the plus is that the repair potential of these joints is far greater than hyaline cartilage line joints. And we covered that a little bit earlier. It is truly fascinating that there's a muscle attached to a meniscus. It's just you would think it's a recipe for disaster, but in general it's not. So, probably one of the take-home messages is fibrocartilage line joints are not designed for long-term compression. Full stop, exclamation mark. If we can tell our patients that, and if they can get their minds around it, that you are halfway to getting this system running smoothly, because it repairs so well. It should be noted that the metabolic support for the fibrocartilage, or the fibrous disc, can have a bit of cartilage in it as well, is via synovial fluids. And if you're squashing it for long enough, the cells within that fibrocartilage, fibrous tissue, don't do very well. They're metabolically starved, not happy. Highly responsive to functional loading. That works in our favour, but it also can degenerate the joint if inappropriately loaded. Okay, here's another fascinating one. It's a bilateral system, and the fossae point backwards. If you're putting hinges on anything and you don't line up the hinge axes parallel, when you move that system, it binds because it can't move. Well, we have non-parallel fossae and condyles. So how does it move? Good question. Well, it really is, because it's a gliding and sliding joint by nature, and it copes with that alignment joint. Yeah. So let's have a look. Condylar fossa, beautiful. Articular eminence with cartilage running to about here. Little bit of wear on the eminence. Interesting. Oh, osseous wear. So the condyle will move under normal circumstances from here to beyond the greatest downward concavity of the articular eminence. Here's another fascinating thing. The two, if you line the the fossa, the outer and the inner eminences, that's where the condyle sits, it points to the anterior foramen magnum, which happens to be the axis around which the head moves, which is quite fascinating, that the jaw system in lateral excursion, side to side, the overall arc of vectors runs through the central axis of the head and neck. Quite interesting. Probably because it's not generating unbalanced forces, I'm surmising. But these natural occurrences are quite fascinating. Why is it so? You can see that fossa is pointing that way, and this one is pointing that way. I would estimate that at about 30 degrees variation. And interestingly, the condyles don't quite match the fossa. These are less inclined to each other. So again, quite fascinating. It's not a parallel surface, it's slightly more prominent medially. Okay. What makes it special? It has a hugely disproportionate representation in the motor and sensory cortices, and not just that, it is hugely linked with personality, emotional expression. So it's not just the motor and sensory cortex, it's linked to the frontal cortex. It's a very touchy-feely, highly sensitive, integrated system, and yet it can load up to about 150 psi, which is, as you might know, fairly strong compression forces. Okay, so we go from kind of pharynx right up to face, maybe 40% of the sensory cortex, similarly with the motor. But it's not just that, it's the linking to personality that really matters. And nice people tend to overuse their jaw system. Lots of mechanical sensors just in the TMJ. So, how can such an intricate, specialised system, multifunctional, richly innovated, become damaged? Okay, this is kind of a drawing I make for my patients. I say, this is the condyle, teeth are down here, this is the disc. When it moves open, it moves together. Disc, condyle moves together. If this is the fossa, the disc runs on the fossa. Problem is that this is attached to a muscle superior head of lateral pterygoid, and we've just got elastic tissue behind, actually going through to the ear in quite a few people. So, if we put compressive force up here, as in clenching, the system undergoes some contraction every time the teeth touch. There's a myotactic reflex. If you lightly hold the teeth together, they chatter on, off, on, off, on, off, because it's either on or off. It doesn't like feather-like contact between teeth. So every time we touch our teeth, it's either contact or not. And contact induces an upward compression through the condyle. Worse than that, when that happens, lateral pterygoid contracts to stabilize everything in this area, but it unfortunately pulls on the disc. Eventually, the disc, the lateral superior head wins, and this tissue gets stretched and it falls forward and medially. And it's at that point that the clicking occurs. So the disc is pulled off. When we open, condyle clicks in, that's the click. When we close, clicks off. So that's a reducing dislocation. If that process goes further, disc goes all the way off, and the person can only open 2/3 maybe, if they're lucky, and it starts to get sore because the discal tissues are getting compressed. A lot of innervation in these tissues. And this is actually not a very good representation because the discal tissues, the capsule is attached up here. But anyway, it gets squashed. So that's a locking of the jaw in some people's parlance. When you have a person with muscle spasm, it's acutely compressed and the muscles are trying to protect the system, just as it does in the back when a disc pops out and compresses the nerve, everything spasms. Pretty good. It's a bit like biting your tongue. Momentarily, everything just spasms. So it's a very smart system. So to get it better, we like suspension of the jaw so that this space is increased, tension's taken off. Oh, by the way, lateral pterygoid, only muscular mastication that opens the mouth, where like crocodiles maybe, lots of strong compressive closure, not very strong opening mechanisms. That's the only muscular mastication. The others are genohyoid, digastric, masseter's our big compressor. It's the big kahuna, or one of the big kahunas, and we'll get to that in a moment, but thank you. Anyway, opening is not a powerful process, and it's basically run through one muscle with the help of a couple submandibulae guiding, which probably means when we're opening our mouth, we probably should raise our head to get these muscles working even better. So if I see you doing that, I'll know you're taking notice. Okay. But that's true. If you try to open with the head down, there's a lot of compression of tissues and a little bit more compression up here. Well, this is the gospel according to Tuffley. It really is an overload and repetitive strain pattern of use. And it does occur unconsciously. We're not thinking about how we're chewing our food. We're just chewing, taking careful notes of what the nice presenters giving. So it's unconscious, it's inbuilt, and it's often a response to stressful or intense situations. It's an emotional response. It resulted, I always say to my people that come to see me for this, I say, and I look them in the eye, I say, good people do this to themselves. And I've had one person that said, did you do it to yourself? One! I would have thought that was pretty obvious, but anyway, true story. And I said, yeah, good people do this because they're earnest, caring, and tend to express feelings through their jaws, their facial jaw system, which is fine, but we can't hurt ourselves. By the way, overuse is defined by damage being induced in any of the tissues involved in the system. If it's damaging, it's too much for that person. It may not be too much for another person, but it's too much in that person's system. So if you're seeing problems in the jaw joint, sore muscles, worn, cracked teeth, losing teeth at mature age because we're crunching them at night, that's too much by definition. So teeth together postures provide a sense of security. Of course it does. We all do it. If we're being charged at by a stegosaurus, we're going to clench our teeth, or tackled on the football field. It is more a stressful or dangerous situation that it's built into us to do it, but not sitting in our car late for our first appointment of the day, stuck in traffic. What are we doing? We could be clenching. Most likely we are, because I'd guess that most of people in this room are good people who care, earnest, conscientious, smart, and can hurt ourselves. Okay, so why does it happen? We're only human. And there's a line in that song that says, I wouldn't be telling you if I hadn't been there myself. And I always say, take it as a compliment, good people do this to themselves. I get their attention by telling them that. I've had probably a couple of people who probably their self-image wasn't that they were good people, and it didn't quite hit the mark, and I'd probably lose them at that point in the conversation. But I can tell you 99+% people do view themselves as good people, and I say, look, if you're a beach bum at Byron Bay, do you think you're going to be clenching, looking at the surf? I don't think so. We're earnest. We've got stuff on. We have responsibilities. We're busy. We do things. Shakers and movers, perhaps. So, okay. Can it really be this bad? This was not a word of a lie. That was in November last year. I feel like throwing myself under a bus. Postpartum, a few months, really sore jaw system. That's how she started the conversation. I went, oh, okay. Not really, but so I said, okay, well, we'll do this, which I'll put up shortly, and we'll see how we go. But you could see at 6 o'clock that night, things were under control, and they only got better from there. It wasn't just the drugs. She was actually managing her jaw system. Of course, there are other reasons why the TMJ may not be very happy, and that is one. Oh dear. He's got his arm caught, he can't even save himself. Okay, so what are the structures involved? We've dealt with some of them. The joint itself and surrounding structures. Yeah, I think we've dealt with that. We've dealt a little bit with the disc being pulled off by excessive superior head of lateral pterygoid tone. It's really a tonal thing in the muscles, so we really want, when we're treating it, we really want to restore ideal tone in the muscles of mastication and also the supporting muscles, because there's a lot of other accessory muscles involved. So this tissue gets squashed and it can be quite sore. And that would click when the person opens. So if it clicks early, it's not very far off. If it clicks late in the opening, it's a fair way off and probably imminently ready to non-reduce. Okay, here's another really interesting fact, and the dentists in the room will probably attest to it. When things are really unstable, fatigued, sore, and if you did EMG on them, it's very spiky, non-coordinated muscle activity. That's what happens. However, it's not just muscle instability, it's nerve instability, because in those people, if they think about this area, quite often a wave of pain will just flow over the area. What is that? That's antidromic conduction. That is reverse fluxing down sensory nerves. It's a big deal. So if people will not tell you that because they think they're wacky. They're making it up, hypochondriacs or whatever. They won't tell you. And if you say to them, yeah, does a wave of pain just come over when you're thinking about it? They go, yeah, doc. And then you're sort of building the rapport. That does happen. And the other thing that happens is they lose proprioception. They don't know where to put their jaw. Trying to get jaw registration. Where's the jaw going? Oh, here, there, oh, everywhere. Because it's all out of kilter. Proprioception's not accurate. Sensory nerves are unstable. The muscles are unstable. It's a mess. That's why that lady said, I feel like throwing myself under a bus. That's where she was. So, courtesy of Nurofen. Do you think this happens fairly often? This is temporalis. Where's it attached? Coronoid process of mandible. Muscular mastication, V3. Oh, by the way, if we are looking at the base of skull and we looked at foramen ovale, which is where the third division of trigeminal nerve exits, it's huge. This area is richly supplied neurally, and we saw how rich it was in the representation in the brain. Okay, so we should be able to get it better, and the joint is highly responsive to functional loading. So, do you think this happens quite often? This pain focus is in the front of temporalis. Temporalis moves the lower jaw. It's an elevator of the lower jaw. Why does it get sore? I normally say it's like hanging onto the steering wheel too tightly for too long. What happens? Arm gets sore. Same with the teeth or the jaw system. You hang on to it too tightly for too long, get sore. That is a sign, classic sign, of jaw system fatigue, overload, repetitive strain. And do we think that it happens often? Absolutely. However, you'd be asking, what about frontalis and cleidomastoid? They are accessory muscles. This is a system within this system, and these guys can get involved, not always, but they certainly may be. Sternomastoid fairly often, because head and neck posture tends to get distorted a little bit when the jaw system's out of kilter. This is more frontal occipital tension, so that is not absolutely a direct result of jaw function. This is, or in Macedon. Look at that big kahuna, and medial pterygoid mirrors it on the inside. Same path, just either side of the mandible. Okay. The major muscles and medial pterygoid on mirroring aceto, but there's heaps of other areas that can be involved. Look at the musculature of platysma, vicularis oris, this lovely aponeurotic connection between frontalis and occipitalis. They're all involved. When we're treating jaws or stomatognathic systems, always we're aware of head and neck and body postures, because working postures can influence this system. For instance, air traffic controllers in Darwin some years ago had a unilateral headpiece. And they're leaning over. They were all getting jaw system problems. Not all. There was a very high instance of jaw system problems. So habitual postures matter. Talking on the phone like that, although it doesn't happen as much now, but putting data in and holding the phone like that is a recipe for disaster. Okay. Certainly the teeth and supporting structures can be affected. Wolff's Law. Oh my goodness, this is an actual patient I operated on late last year. I thought, I've seen worse. That's Wolff's Law. That's his bone responding to functional loading. Look at the wear on the teeth. So dear Julius Wolff stated, bone in a healthy person or animal will adapt to the loads under which it's placed. Pretty true, thankfully. Makes it hard to get the teeth out sometimes. Okay, so how do we manage it? Oh, notice I say manage. Some would say treat. It probably... Daughter did that. Manage it. In my opinion, primarily, the initial first up aim of treatment is to manage and appropriately modify and balance muscle activity. There's a muscle sling. This is a suspensory unit. The jaw joints tell us they are sliding, gliding units. This is not designed for long-term compression. Do not do that if you want the jaw system to work well. It's held by this beautiful, powerful muscle sling. And you need to keep in mind body postures as well. So, this is really Tufts' law. TMJ is high responsive functional loading involving cartilage, bone, muscle, dental adaptations, and they do adapt. This is a guy about my age, maybe a year or two older, really nice guy, loves sailing. He had an injury to his left TMJ when he was still growing. And you can see the shape and length of this is different to what we would consider the normal side. Fairly strong muscle attachments, and that bone has adapted its shape. You can see that the orbits are pretty level, but the occlusal plane is quite markedly tilted. Does he have a problem with his jaw system? Does it work okay? It works perfectly fine, but it's adapted. So, wait for this. Let's see what it looks like in the flesh. One of my all-time favourites of both types of music. Middle age. Start to see what's happening to his chin and length of jaw. Middle age. Whoa! Johnny Cash in older age. It adapts. Did he have a jaw joint problem? I'm not sure, but he sang pretty well most of the time, not always. Did you know a boy named Sue was done cold? He got the poem the night before, turned to his band and said, play something in G, and he sang it to the audience at Folsom Prison. It was one of his biggest hits. So you'd see, if you see the video of it, you see he was actually reading it for a little bit, and then he got right into it and didn't read it at all. Pretty good. Play something in G. Actually, the radiologist couldn't quite work out what was happening with this girl. She's about 16. Okay. And you might think, oh, it looks fairly reasonable. Midline's pretty good. She's had wisdom teeth out. Oh, wisdom teeth trying to fit into this space. Not enough room. I didn't take them out, by the way. But then you'll look, what does the left side look like? Fairly normal, nice fossa up here. These are always taken with the lower jaw forward, biting on a block to get both arches lined up and in focus. So always the so-called OPG, or rotational tomography of the jaw, is always taken with the jaw in protrusion. So that's out of its fossa. Whoa, check this out. This girl had severe juvenile rheumatoid at age 1, approximately. Joint just really hyperplastic. A new fossa here, slightly changed osseous profile, or somewhat changed. Midline's fine, and fossa up there. So in this instance, most of the adaptations were skeletal. And very much anteriorly placed to ramus. If you look at where the anterior atlas arch is there, and it's there, so it's at least a centimetre or further, or more, further forward. Does she function quite well? She functions quite well. Not perfectly. And by the way, you can cut off the condyle, gone, or it can be destroyed through a rheumatoid process. This joint's not highly vulnerable to rheumatoid processes, but it can be affected. So you can actually lose your condyle, and the only proviso for the system to work is if the muscles are of correct length and coordination. I would excuse people that have dystonias and such, and that's a different kettle of fish. But normal muscles allow the system to work, albeit with diminished biting force. Very interesting. Okay, this is my recipe for getting it better. And I have to get it pretty right most of the time, or my patients won't love me. So, first up, they need to know that it's not a sustained loading system. And here's a kicker, and it's not always taught. You have to become aware. A little pop-up in the consciousness has to come and say, "Good morning, Mark. Your teeth are together. Do they need to be together right now?" And that has to happen every time your teeth are together, sitting in the car, waiting for the lights to change or some other frustration. And that gives control. And that is taught. You can teach the brain to do that by checking regularly over a few days. And then our lovely brains get the idea, teeth together, a pop-up in the consciousness is required. Then we have control, we have choice. Okay, so awareness of when teeth are together, it's critical. If you don't have that, the person just keeps on doing it unaware. You must have awareness. And you need to employ correct control. What is correct control? We use tongue and lip postures. They're very sensitive. Correct tongue posture is up behind the up front teeth on the rugae of the anterior volar palate. And it should stay there all the time. The only time that it's not there is when we're talking or in deep sleep. That's its postural position. The tongue has all the controls for all the muscles in the region, the tonal controls, all the levers. It will manipulate the system to an optimal tonal pattern. Lips need to be lightly together. You cannot breathe through your mouth and have optimal mouth posture. Hence, sometimes referral to ear, nose and throat. If we want to get the system better, we are somewhat stuffed for options if the person has to breathe through their mouth habitually. It doesn't support the jaw. So if it's supported here, it relaxes there, all the muscles are happy. Speech, swallowing patterns. Oh, maybe I should deal with swallowing. Bad swallowing pattern for the tongue and lower lip to form a seal. That is manifest by these muscles contracting. It is a very bad, inefficient pattern of swallowing. Swallowing should commence with the tongue up behind the upper front teeth, as if saying la la la, then the letter N. Good, we're almost done. Yeah, see, the teeth and the TMJs do interact, they talk together, but they are end organs. They cop the beating from the muscles. So what should we deal with first? Probably the one doing the beating. But good occlusal support is required. I'm not saying optimal or ideal, but it has to be reasonable. And we should know, here's the catch, teeth are meant to meet and greet each other. They're meant to function. But it's a balance between adequate function and hyper or over function or damaging function. So we actually have to, each of us has to teach ourselves what's correct for us. We use the soft splint, resilient splint. We call it a re-education splint. It tends to turn off the impulse to clench while we're sleeping. It opens the mouth up a little bit, as we saw in the head and neck posture geometry. If the head goes up a little bit, it does significantly influence the volume of the oral and oropharyngeal areas. We love these because they are simple, cost-effective, and we tend to use them only for a couple of months. Although some people like to use them whenever they're in stressful circumstance, and they tend to clench a little bit more. These are the treatments that we gave to the lady who wanted to throw herself under the bus. So we give information. In fact, I've got information packs if you want to see what we give. They have to control their oral system. They have to be aware of what it's doing. They do. That's important because if you get it right through the day, over time the nighttime activity tends to calm down. But some of us are really good at doing this, and we need pretty well immediate intervention. So that's why I quite often, but not always, use a splint early. So we love heat packs, we love paracetamol, love the omega-3 rich oils. I like sleeping with the head elevated, and as Karen said earlier, not scrunched up because it pushes the teeth together. Fine. And in fact, it can be a bit stormy, but there is light at the end of the tunnel, and it can be quite peaceful once we get hold of it.